Hi, I'm Alicia.
And I'm Robin, and you're listening to Bowel Moments,
the podcast sharing real talk about the realities of IBD. Served on the rocks. This week, we brought back a couple of our past guests to do an episode of Research Roundup. We brought back Dr. Sunanda Kane and Dr. Lukasz Kwapisz. Dr. Kane is a professor of medicine at Mayo Clinic in Rochester, Minnesota, and recently published the book Mayo Clinic on Crohn's disease and ulcerative colitis, Strategies to Manage IBD and Take Charge of Your Life. Dr. Kwapisz is an assistant professor of medicine at Baylor College of Medicine in Houston. Both of them are IBD specialists, and we talked about all the latest and greatest in inflammatory bowel disease research. Cheers. Hi, everyone. It's Alicia, and welcome to Bowel Moments. And I am flying solo today, hosting-wise, because Robin is in beautiful Scotland without me. I'm very disappointed, but I'm glad she's getting a much-needed vacation. But I am really excited to be joined by Dr. Susie Kane from the Mayo Clinic and also Dr. Lukasz Kwapisz from Baylor College of Medicine in Houston. Both of them previous guests, and we'd love to bring you guys back to do Research Roundup, which I always feel like I should have guns shooting at this point, so we can talk about what's new and exciting in the world of inflammatory bowel disease. But first of all, Dr. Kane, I see you're still in clinic, so I'm guessing you're not drinking anything super exciting.
No, my bottled water.
And Dr. Kwapisz, you just said you got done doing a bunch of procedures. So are you drinking anything with me tonight?
I have an essential water, and I just had a Houston mug from Starbucks. I don't know if you guys collect these mugs. I'm such a sucker from like certain cities, and I collect these Starbucks mugs of my favorite cities.
I actually grabbed the last Charlotte Starbucks mug from the convention center as a gift for one of the ACG staff who collects them.
Well, there you go. So yeah, we both like it. So I had coffee and water, but no drink yet.
All right. Well, I decided to drink a little tiny amount of scotch in honor of Robin being in Scotland. I'm having a little bit of scotch, but I also am drinking just tea as well. So a little bit on the boring side for me over here. But you guys mentioned that you were just at ACG, which stands for the American College of Gastroenterology. It's their annual meeting, correct? That's how they phrase it?
Correct.
Yes, nodding. Okay. So tell me, what were your major takeaways from this annual meeting?
Lukasz, do you want to go first?
Well, I can't believe the ex-president of ACG is letting me go first. I definitely should have deferred the floor, but I'll just briefly say, I think it's an exciting time for both Dr. Kane and myself and all of us who are in the IBD world with all the new medications that are coming for both ulcerative colitis and Crohn's disease. It is an exciting time. For the longest time, we had limited options, I would say, and Dr. Kane can talk about that even more historically. But now 3 new agents were released this year as per the FDA. Many more are coming down the pike. And this is just an exciting time for our patients mainly. And even for us clinicians, it, I think, inspires us. It motivates us to maybe one day find a cure as well. And I think we're getting closer and closer with some of the remission rates that we're seeing both endoscopically and clinically. So for me, hearing the new agents coming from an IBD perspective was by far the most exciting part for me. And now I will defer to the president and probably, the one who matters in this conversation the most.
The past president. And
okay, past
being so kind. The word is old. I practiced before there were any biologics, so that really makes me a dinosaur, right? So
I think it makes you an innovator, really, if you think about it.
So I say that before biologics, we had steroids, we had azathioprine, and we had hugs. I gave out a lot of hugs, and I still give out a lot of hugs. There is something extremely therapeutic about a hug. Anyhow, so I totally agree with my colleague Lukasz that really sharing some of the extension data, some of the safety data, some of the in the weeds, if you will, data from the registration trials of the newly FDA approved therapies so that we can feel more comfortable about who we should prescribe these to, who we should perhaps not prescribe these to, how much can we push the envelope in terms of dosing and frequency, and that we don't have any new safety signals with these agents now that they are available. So, ACG is very much about clinical research and helping clinicians. And so, the emphasis definitely was on medical therapy and management of complications. And so, some takeaway messages that we were able to bring back to the clinic the next day.
That's awesome. Well, and the ACG also is not just an IBD meeting. So there's lots of other types of gastroenterology that's happening happening there as well. But I think it's exciting to hear about new medications, that are being introduced and coming down the pipeline. Let's stay there because I know we want to talk a little bit about there. You said there's 3 medications that were approved this year already, and there's some coming soon, it sounds like. Let's talk about what are the 3 medications and how are they different than what's already out there? And then I'm going to also give you another caveat. Sorry, not to give you 3 questions at once, but also we had talked a little bit about biosimilars as well. So let's roll biosimilars into there as another additional option that's coming down for a lot of people living with IBD. So let's start with brand new medications. What's exciting about them? What's different? And then let's move on to biosimilars and kind of let people know a little bit more about what's happening there in that development. Does that sound good?
Sure.
Okay, maybe I'll talk about the 3 medications and I'll let Dr. Kane talk about biosimilars. But, this year for ulcerative colitis, we had 2 oral small molecules that were approved. Ozanimod, or Zeposia is the common name, and upadacitinib or Rinvoq. And these are oral options for ulcerative colitis, which, Rinvoq especially, I feel like is on every other commercial on TV. But, this is exciting because for our patients with ulcerative colitis, aside from mesalamine and prednisone, and, now I generally don't use much azathioprine, and maybe Dr. Kane has a word on azathioprine and ulcerative colitis, but we haven't had many oral options, or we haven't had any other oral options besides what I mentioned. And there was a lot of injections and infusions, and having these 2 agents become available has been great for a lot of our patients. Now, there have been some FDA labeling with Rinvoq specifically, and I'll use the trade name as not a first-line agent in TNF failure or refractory to TNF agents, which, is not a first-line agent, which makes it a little bit more difficult for patients to get. But Zeposia or Ozanimod is first-line, and it's been a welcomed addition. I mean, I think community gastroenterologists are still probably more lukewarm in using these 2 agents because of perhaps, some of the side effects as it pertains to Zeposia, having to get an EKG done, or if they have diabetes, maybe they need an eye exam, checking varicella titers. Like, these are newer things that maybe our community GIs are not as comfortable with, but it's been great, I think, to just have those options in ulcerative colitis. As it pertains to Crohn's disease, we have Skyrizi is the trade name, or risankizumab, that got approved. There's still some difficulties across the country in getting these infusions. Like, I could speak on it at our institution, we still do not carry the infusion for risankizumab. We have to go through third-party infusion centers to get it. But this is the newest agent in Crohn's disease, which we haven't had one in, I think, 4 years that got approved, something around that. So that's been exciting. And there's a new on-body applicator, which is a newer technology that our patients like as well. And yeah, so I think from a IBD perspective, both patient and clinician, it's welcomed to have new options in ulcerative colitis and new options in Crohn's disease. And what we saw at ACG to extend that is, some of these agents, while approved for one condition, are often going to be approved for another condition. So for example, Rinvoq or upadacitinib, there was a lot of data that was coming out for Crohn's disease. And by all accounts, it appears that it's going to be available next year for Crohn's. We heard some of the discontinuation rates of Ozanimod in the True North study, how that's detrimental. And in fact, it's great to just keep patients on it because it prevents, their disease from reflaring again. So that was great to hear. And Skyrizi one day is also going to be available for ulcerative colitis, where right now it's for Crohn's disease. So all these things are going to be adapting and changing. And for us, it's great to have extra options. And I'll let Dr. Kane add in some additional things if you have to speak on those agents and biosimilars, because I'd love to hear your take and your thoughts as to where we are right now.
Right. So it's interesting. We're having the same problems with Skyrizi, and that what's interesting is that because these are, medications that were used for different autoimmune diseases, people are already familiar with the name and the jingles that go along with them. So I can't get that stupid Skyrizi jingle out of my head. But what's nice is that for a lot of our IBD patients have skin issues. They have some eczema, they have a little bit of psoriasis, and that their skin will be clearer and healthier when we are doing a twofer with these agents. That he's absolutely right in that we're going to have to start thinking about other things that we have to do before we can give patients some of these agents, so that it means that we have to understand how they work, right? So Alicia, you were asking about, can we take a step back and say, okay, we've got this Chinese menu of all these agents and that we have these different classes and we have multiple in each class. But wait a minute, what are the different classes? And just because you throw out a name, well, what class is it in and how is it similar or different than another medicine that might be in the same class? And we're getting all excited about a new medicine, but it's actually just a spin-off of something that's already out there. And the patient's going, well, I've already been on that. So how is the spin-off going to be any better for me? So I think it's definitely worth just taking a step back and that we spend a few minutes, Lukasz and I, just like explain, IBD meds for dummies, what each of the classes are and how they work and how they might be different, because there are now us smarty pants IBDers who are mixing and matching. So we've got patients on two different ones. And why would that be helpful? And so we're trying to take advantage of the way the mechanisms of these meds. So Lukasz, why don't you walk us through, why don't you take anti-TNFs and interleukins?
Yeah, sure. Let's start off with, we mentioned the three names. So I'll just, we should have mentioned the drug classes, and I apologize that I didn't do that. But when we look at, Zeposia or ozanimod, that's an S1P, they call it agonist. And the principle there is that we're trapping, lymphocytes inside lymph nodes. So whenever there's inflammation in the gut, there's perhaps a cell signaling pathway that triggers a cascade of further inflammation to get to that area of the gut. And in the case of Zeposia or ozanimod, we are trapping the inflammation within lymph nodes so that it doesn't travel to the gut and thereby cause more inflammation and more damage. So that it's an interesting mechanism of action. It's the first agent in ulcerative colitis with that mechanism of action that's been approved. Although this drug has been used in multiple sclerosis, and that's where it's well known. And I think there's 4 other S1Ps that have been studied in multiple sclerosis and probably eventually will make their way down into ulcerative colitis management. Dr. Kane mentioned interleukins. So when we talk about Skyrizi for Crohn's disease, it's an IL-23 inhibitor or interleukin 23 inhibitor. And if you think of what we've already had, we've had ustekinumab or Stelara, which is IL-12/23. And now the newer version, or maybe the remix of what we have, something slightly what we probably perceive as better, are interleukin 23s. And there'll be many of these agents coming down the pike. Mirikizumab was presented at ACG. There's brivacizumab. There's many agents. And risankizumab is the first one that's been approved for Crohn's disease. And what we found is that blocking perhaps interleukin 23 is all that's needed to help reduce the inflammatory pathways that affect Crohn's disease, perhaps. And this is particularly interesting. And there's been a head-to-head trial in, I think, psoriatic arthritis, I believe, as it pertains to ustekinumab, the IL-12/23s versus risankizumab, just the IL-23. And the IL-23 was superior. Risankizumab was in fact superior. So there's the thought process that same data perhaps may apply to Crohn's disease. I had heard that we should have head-to-head trial data in 2023 with those two agents. So that'll be interesting. And then I mentioned Rinvoq or upadacitinib. That is a JAK inhibitor or JAK-STAT pathway that we're blocking. And, again, it is much more specific. AbbVie genetically engineered this molecule called Rinvoq, which Dr. Kane mentions she can't get rid of the Skyrizi jingle. I can't get rid of the Rinvoq jingle. But it was really interesting. But AbbVie tested 1,700 different combinations of blockade of the JAK inhibitors. There's a JAK1, a JAK2, a JAK3, and a tyrosine kinase 2. And they were trying all these different permutation and combinations to try to block just one particular pathway, maybe just the JAK1 preferentially. And that seemed to produce lower side effects, lower myelosuppressant or blood count drop effects. And, that's also, it's quite interesting, right? Where science is going. So I think those are the 3 new agents. There is a JAK inhibitor already in ulcerative colitis that's been approved. That's tofacitinib or Xeljanz. And now Rinvoq is the second JAK inhibitor, but again, works differently and genetically engineered to be blocking more JAK1 specifically than the other pathways. And yeah, so that's my side. I don't know if Dr. Kane, you have something, probably more impressive to add than what I just mentioned.
No, that was a tour de force. I think the important thing here to remember is that the human immune system is super complicated. It's replicative and duplicative. What does that mean? It means that you block one area and the body will figure out how to circumvent that blockade and still cause inflammation. So the trick here is to try to pinpoint the exact pathway that is associated with Crohn's or ulcerative colitis in such a way that you are not causing a blockade for other immune things that are needed to remain healthy. So there are obviously different ways to do that. You can stop the lymphocytes, which are the white blood cells that are involved with the immune system, from ever leaving home. So if they can't leave home, then they are not able to cause trouble. So that's what those oral agents do. The interleukins are an entire family of proteins that wreak havoc on our bodies in different ways. So there's at least 23 of them, right? Because interleukin 23 is what we're using for inflammatory bowel disease. But interleukin 17 is used for other autoimmune diseases, not IBD, and actually makes IBD worse. But there's IL-10. And so if you enhance IL-10, then that's actually good for Crohn's. Those trials never made it out of phase 1. But so those are different classes. But then the other two classes of therapies are the anti-TNF agents, which were the first ones to market. TNF stands for tumor necrosis factor, which sounds really scary because it sounds like we're treating cancer. But it just turns out that tumor necrosis factor is a protein that is manufactured by a very revved up immune system and causes all sorts of havoc. So we want to suppress that protein. And so that's what Remicade, Humira, Cimzia, and Simponi all do. So that was the first class of medicines. The problem with TNF is that it's everywhere. It's through the whole body. So this is very non-specific, non-selective. And what Lukasz has been talking about is trying to then, select much more and pinpoint much more targets that then you are not affecting the entire body. So anti-TNFs, and then there's the anti-adhesion molecules. So those lymphocytes may actually leave home. They leave the lymph nodes, but that if you can prevent them from attaching to a target, then they can't cause the downstream inflammatory effect. And that's what anti-adhesion molecules, so that's Entyvio. And right now, that's the only one that we have for IBD, but Entyvio is IV right now, but some of the newer research we heard is that we are getting the shots of Entyvio. That should be hopefully the first quarter of 2023, we will be getting the subcutaneous shots for Entyvio. And then just to finish everything off, just to make everything that much more confusing, is that the anti-TNF agents, now because they've been around for such a long time, that other companies have been able to take the molecule and that some parts of that molecule have to be the same, but other parts of it can be manipulated and look a little different. So now we have what are called biosimilars. So not generic, but biosimilar. So the example that I use with my patients is Coke and Pepsi. So those are both colas. They both have the same appearance and the same function, which is to quench your thirst and to use as a mixer with your rum, but or your Jack, whichever, since we're talking about whiskey. But that these other companies can do it a little bit cheaper because that they have the technology now that doesn't have to be created. So there are already five, Lukasz, biosimilars for Remicade. And now we are getting our first biosimilar for Humira, which comes out January 30th. And it's going to be called Amjeveta and will work similarly to Humira. And whether we're going to see Amjeveta commercials, I'm not sure, but that is going to be very similar to Humira. The studies have been done to show that it is similar in efficacy and safety to Humira, but that it is not considered interchangeable. So what that means is if you are on Humira, that we will not change you over to Amjeveta, but you could get started on Amjeveta and do fine. We will have another 7 biosimilars for Humira in July of 2023. And so ultimately it's going to be which company probably has the best offering in terms of pricing and contracting with insurance carriers, and also what's most attractive in terms of the patient support program, and for providers, what's the path of least resistance, which medication is the easiest to prescribe, get the fastest, because at the end of the day, they're all the same. And that's the important takeaway here. They are all the same. There's little nuances here and there that perhaps an individual may have a preference, sort of like, you can tell the difference between Coke and Pepsi, but at the end of the day, it's a mixer and it's going to quench your thirst, right? So it's not that you're allergic to Pepsi and that you can only drink Coke. You might prefer one or the other, but ultimately they're the same thing.
So I'm curious, just from, your perspective and also as patients are looking at their options, because it's fantastic that we have so many more options for patients. But if you start on a class of medication and it perhaps doesn't seem to work for you, does that mean you automatically won't respond to the other medications that are in the same class and you have to move into a different type of drug? Or is it that it just might be something about that specific medicine that doesn't work for you?
I think I'll let Dr. Kane answer this, and then I have some thoughts that I'll come through with after.
This is where it gets nuanced, and we really, this is where taking a history and talking to your patient actually becomes very important, because there are patients who honestly don't get any better when we give them a therapy. And so we would call those patients primary non-responders, and that it doesn't make a lot of sense to try to reinvent the wheel and give them another medicine in the same class if they truly had zero response. So like, doc, it was just water in that IV, or it was just sugar water going in the injection. There are patients who have a partial response. And then the question is, well, is it because they need more, or is it because of some genetic makeup that they have, or is it because they are male versus female? What is it about them that gives them a partial response that perhaps if we give them more, they will overcome that barrier? And then there's the folks who have a great response for 6 months, and then they lose it. And then it's like, well, you had a really good response for 6 months. Yes, let's move you over to another one in the same class, because we think that, with that kind of success, that we will have success with another agent in that class.
Yeah. And just to amplify that point, because that's exactly how I approach this. Like, if someone has had a response to, let's just say within the TNF class, like if someone has had a response to Humira, but then after a certain period of time, perhaps loses that response, or there's attenuation, there isn't as good of an effect. Maybe we check antibody levels and it shows that they have antibodies. That doesn't preclude them from staying within the class and just cycling within the class rather than swapping out of class. You could just cycle to, from Humira to Remicade and Remicade to Humira, especially if there's been a primary response. So if you don't have that, then I agree. Now, you could compare Xeljanz and Rinvoq. They're within the same class. They're in the JAK class, but they're blocking slightly differently, right? Like I recall, I mentioned that there's a preferential blockade of a certain, subtype of the JAK. So perhaps, if someone didn't respond to Xeljanz, that doesn't mean that they won't respond to Rinvoq. Although with having all these different Chinese menu options, this buffet option, you don't have to stay within class. Perhaps at that point, use your, options and you switch completely out of class if there's been no response whatsoever. So I couldn't agree more that initial, and I learned from Dr. Kane, so it's easy for me to, amplify the point, but if you've not responded to a specific class, switch out of it. And now that we have more options, that's fantastic.
Okay, I want to stay with medications for a little while longer, but I want to move slightly different direction. So, Dr. Kane, one of the studies that you wanted to talk about was that there was a study that came out at the end of September about pregnancy and safety with some of the, I think it was the anti-TNF medications. Is that correct? Right. So let's talk about that.
Right. So this was really great news that got published just last month in a non-GI journal. So it was Annals of Internal Medicine, because there are not just gastroenterologists who prescribe and use anti-TNF, because as I mentioned, it's used for multiple things. So this was looking at the European population, particularly French French population, and the Europeans have been a little bit slower than the Americans to get on board with the thought of how safe that continued therapy is during pregnancy with these biologics. And so this was a very large population-based, meaning every patient who got pregnant in France on these agents for IBD were followed. And it turns out that, for the women that were counseled to stop their therapy, that they had almost a 30% increased risk for having a flare during their pregnancy or postpartum, which is horrible. Why would you purposely put a woman at risk for a flare? And that if you continued the therapy, that there was no increased risk for infections or bad neonatal outcomes. So basically, there was no harm to the baby with continuing the therapy, but there was harm if you stopped it in the mom. So the Europeans were like, yeah, okay, now we get it. So the recommendation worldwide now is that if you are on an anti-TNF and you get pregnant, that you continue it throughout your pregnancy, because stopping it puts mom's health at risk, and that continued therapy does not put the baby's health at risk for having been exposed. So it's not groundbreaking, but it's declarative in that it confirms what the Americans and the Dutch have been saying. So the world is now on board.
And that's awesome that you shared that, Dr. Kane. I think you published something with Cara De Felice, I think a year ago too, on the safety of anti-TNF in pregnancy. But, I had always been taught, not only by you, but all the IBD mentors from Mayo, for example, that in pregnancy and IBD, there's the rule of thirds, that a third of our women actually get better during pregnancy, a third get worse, and a third stay the same. And we have always just continued the medications. And typically, if it is an infusion, we stopped it at week 32. Really, we just continued it through week 32 and then restarted post-delivery. But we had always known, at least in North America, that anti-TNF use and exposure during pregnancy with women, not only in IBD, but as you said, in other conditions, right, or rheumatoid arthritis patients or psoriasis patients, that there wasn't any increased risk of maternal or infant adverse events. So this is something that we always knew. And I had always been just continue on and then make sure the baby doesn't get any live vaccines for 6 months, which some people are now saying maybe up to a year. But, that's kind of just how I've always approached it. So it's interesting that in Europe, maybe they're now just catching up to that thought. But yeah, I don't know if you had any comments on that safety. I think you published something, so I don't know if there's anything additional to add to that.
No, but I'll just clarify that the rule of thirds is when the patient has active disease at the time of conception.
Okay.
So if she is well at the time of conception, there is no greater risk for her to flare than a non-pregnant patient. But if she has disease at the time of conception, then a third will get better, a third will stay the same, and a third will get worse.
So in general, you're working with your patients who are looking to get pregnant to get them well as
Correct.
quickly as possible. Got it.
Correct.
All right. Guys, one of the other things that I found when I was digging into PubMed, which is now one of my favorite activities, is a paper on nanomedicine. And I realize this is, again, sort of space age medicine we're talking about. So quite a ways down the line. But what is this about? And it talked about repairing the epithelial barrier. So talk to me about that.
So
Dr. Kwapisz is very quickly saying, you talk about
fancy term. So the endothelial barrier is basically the wall that protects the outside world from the inside world. And when that breaks down and becomes leaky, then bacteria, proteins, all sorts of things can leak through and cause havoc. So if you can, so inflammation breaks down the health of that wall. And ulcers is where there's a frank breakdown of that wall. And so if you can deliver, little Mario repairmen to that wall, and that they can then put in the bricks and the mortar, if you will, to continue this analogy, at that level. So the medications that we've been talking about have been talking about the cells that are involved with the immune system. The the nanomolecules are working at the level even smaller than that, at the level of where the breakdown of the endothelial barrier is, and being delivered right there to repair that wall. It's fascinating.
Yeah. And I mean, I have perhaps more, definitely more of a primitive understanding of all these, nanotechnology and nanomedicines. I mean, my basic understanding of it is the purpose of nanomedicines is to make sure the medications get to the desired area, right? So you want to deliver the drug to the specific sites, and you want to overcome if there's any potential biological barriers, like Dr. Kane was mentioning. So the purpose of these nanomedicines, I think, in my eyes, is to perhaps maybe come up with ways that we can reliably say the medicine gets to the area that it needs to get to. So if it needs to be to the rectum or to the terminal ileum, for example, in Crohn's disease, that we want it to get there. We want to perhaps one day reduce the overall dosage. So if it is a very high dosage, if we can reliably say the medication's getting there, perhaps we don't need that same high dosage. And then you want to make sure we're increasing, our treatment efficacy. I mean, that's the basic underlying principle while minimizing side effects. So, in my eyes, perhaps this is the future. I mean, I think there's going to be some form of artificial intelligence that is going to be coming down the road that, all of us will try to put our heads together is how can we come up with the best technology, the best patient protoplasm in terms of their characteristics, whether they're male or female, even as simple as that, or where their disease is located, or what their fecal calprotectin is. I mean, gosh knows, maybe we'll have 1,000 different parameters we could put into some computer system, which will then help ultimately predict which medication we can use that our patients will derive the best benefit from. And perhaps there's going to be some nanomedicine technology that also helps in that treatment course as well with our plants.
Just playing off of that for a minute, which is not something I necessarily prepared y'all for, so you can tell me you don't want to answer this. But I know we just recently spoke to a patient who has very significant issues with fistulas, and in particular had to have her vaginal wall rebuilt and repaired because of having just such a significant fistula. And I know they're looking at stem cells in this type of repair. So can we talk about that for a minute?
Absolutely. So plug for Mayo Clinic that it was my colleague here, Bill Fabian, who really pioneered this and was the first to publish our results. Now, a vaginal fistula is the hardest fistula to try to repair. And the reason is because you have two organs. So you have the gut and then the genital urinary tract, and they have different bacteria in each of them. And when you try to put them together and when there's a connection, they don't play well in the sandbox. And it's super hard. And those are not the same kind of cell type either. The lining of the vagina is not like the lining of the colon. And so stem cells have been shown to be extremely effective for fistulas that are perianal. So coming off the GI tract, coming through to the outside skin, because those cells are all basically kind of the same. But you can heal up a fistula that's a simple fistula, some that are a little less simple, but we have a long way to go with stem cells in terms of fixing vaginal fistulas. But that day may come. And whether it's that you are embedding the stem cells on some foreign body, like a ceton or a plug, or whether you are injecting the stem cells directly into the fistula tract, or if you are injecting them around the opening of that fistula, we still haven't figured out the best way to introduce those stem cells. So this is not like a stem cell transplant like what we do for leukemia, where you inject the stem cells into the bloodstream, but this is a localized effect where you are using stem cells that grow into connective tissue to heal a fistula tract.
Yeah, and a plug to, maybe not talk all bad about Europe, even though I'm from Europe as well. But I believe in Spain and Barcelona is when they first started pioneering some of these stem cells. So, maybe they are a little bit ahead in some areas as well. But I know there's been, at Mayo Clinic, at Cleveland Clinic, I know Dr. Leitner, who's there, one of our colorectal surgeons who used to be at Mayo, is now at Cleveland Clinic. Sorry?
She's leaving.
Oh, breaking news. But nevertheless, I know she was actively involved in the stem cell trials.
Great.
I'll tell you just, my own personal experience. I don't want to say I dread, but my heart goes out to all our patients, our young female patients who have rectovaginal fistulas. Just the actual idea of, thinking this young 22-year-old girl is saying she's passing stool out her vagina. It's incredibly traumatizing. And, I don't shudder, but my heart definitely goes out to them. And similarly in our men or our younger men, if they're passing stool out their urethra during urination like that, or passing gas that way, like these are incredibly traumatizing things. So if we could come up with treatments besides diversion, which seems like what a lot of us end up doing if it gets really, really severe, and if these stem cells are magical treatments, then fantastic, because this is some of the most difficult situations that we find ourselves in, at least personally, fistulizing Crohn's disease.
Yeah. So absolutely, I should have clarified that Bill Fabian was the first American to introduce stem cells, but certainly the Spaniards were years ahead of us. Absolutely.
Thank you for making all of our European listeners happier. I appreciate that, guys, because we do have a few. Okay, Dr. Kane, we're going to lose you in 10 minutes about. So do you want to do a plug for your book?
All right. So this is the third edition of the Management of IBD written for patients. So this is not a textbook. It is meant and written for patients. And this edition is the third edition of the book. And this time I'm using the Mayo Clinic publishing house, because the publisher that I'd used before, which was the American Gastroenterological Association publishing house, went out of business. This is a book that now is as up to date as July or August of this year. So Skyrizi is in here. The latest data about marijuana is in here. The stem cells are in here. The safety in pregnancy is in here. The diet study is in here. So very up to date. Again, it's written for patients, so it's just enough science that it's not overwhelming, but hopefully helps to clarify and put into perspective what you're going through. The biggest chapter still is what can I eat, but there is still the chapter about surgery, about getting pregnant, a chapter for the parents who have children with this. $20 on Amazon.com.
Awesome. And you, during your episode with us, just your episode, you mentioned this, but it wasn't quite out yet. So it's very exciting that it's out, and people should definitely get a copy. And I will make sure I link to it in the show notes, everyone.
Thank you.
Everybody should get it. It's a wonderful book, and anything that Dr. Kane writes, people should read. So yes, definitely get it.
Well, and Dr. Kane, you're really good at explaining very difficult concepts in a way that's very understandable. So I know your book is equally understandable. So thank you for that.
And I think Lukasz is referring to my weekly fantasy football newsletter that I put out, which was Halloween themed this week.
So I should mention this. So Dr. Kane is, this is how cool she is. Not only, master clinician, excellent teacher, publisher of books, but she's also the commissioner of our fantasy football league. And it's on top of us. Like if someone's missing a roster spot, you're getting an email on Thursday before the Thursday night game, get your rosters in order. But then probably my favorite thing, and it comes after the Monday night game. So usually Tuesday morning, she does this like cool summary where she comes up with a theme. Like this past week, obviously it was Halloween. It was a Halloween theme. Previously, there's been like rock bands from the 80s that I didn't even know. She's like, oh, you're probably too young to know this band, but it's still so cool. And I read it and it's so clever and it's so witty. And this is my appreciation to you being a commissioner, because it's by far like the most fun league I'm in because of these write-ups. Actually, it's just so much fun.
That's awesome. So guys, of course, the highest on everybody's list of topics for patients is diet. And so my friend of the show, Stacey Collins, who is a dietitian specializing in inflammatory bowel disease, sent us a journal article about the British folks, British IBD folks, I guess we'll call them.
The British Dietetic Association.
All right. The British Dietetic Association, thank you, Dr. Kane, came up with guidelines for how clinicians should work with folks with inflammatory bowel disease. And so she was pretty excited about it. I know I just sent it to you guys, so you may not have entirely reviewed it. Can we talk that through a little bit? Because it sounds like it's perhaps a little, getting back to our European friends sometimes are more advanced. It sounds like it's a little more advanced than perhaps the dietetic guidelines we have in the United States. So can we talk a little bit about diet and inflammatory bowel disease?
So Lukasz, I don't know whether you have it open or not, but I can speak to, it looks like there are 14 grade recommendations here. So there's nutritional assessment, and they say that fiber intake is likely to be low with an 88% consensus. Calcium intake should be assessed, which at 96% consensus. So, and then the third one for nutrition assessment is iron intake should be assessed. So I completely agree with all three of those things.
No, definitely. And just to, we all check, I think, nutritional panels in a different way in our IBD patients. I've kind of just gone through the gamut of definitely always checking a calcium and an iron and a vitamin D and a B12. That is absolutely as part of my, blood work, initial screen. I mean, some people will add in zinc, some people will add in selenium, and, I don't typically add those in. I don't know if Dr. Kane does, but definitely as it pertains to those three recommendations, I would say, certainly we need to, and with fiber, this is interesting because it is controversial to some people. There's some clinicians who think our Crohn's disease patients shouldn't have fiber, right? Dr. Kane, what do you tell your patients about fiber as it relates, perhaps maybe to Crohn's? Yeah.
Right. Well, so the statement is that fiber intake is likely to be low in IBD and should be included as part of a nutritional assessment. And I totally agree. So, not all fibers are the same, right? So there's soluble and insoluble. And so that's the conversation you have to have, that insoluble fiber may not be so great for somebody who has a stricture. Soluble fiber, which means that it's water soluble, is very healthy and should be part of everybody's diet. And it's like, that's like the moment that people have, like, what do you mean I can eat cream of wheat and oatmeal? Yeah. You should not be eating raw cauliflower or the raw celery and raw carrots, because that is insoluble fiber and will get stuck and will be non-digested and sit on inflamed tissue. But that we should all be eating, enough soluble fiber, because it's good for glucose control, weight control, and our cholesterol. And our bacteria in our colons need that fiber for being healthy. You got to be kind to your colonic bacteria.
Has there been any other diet research, so not necessarily this one, since I know you guys are still kind of glancing at it, but has there been any other diet research that's been particularly interesting or intriguing to y'all?
So Jim Lewis at the University of Pennsylvania headed up a study looking at a comparison for patients who had mild to moderate Crohn's disease between the specific carbohydrate and the Mediterranean diets. And that the patients were given 6 weeks of free food. They were randomized to one or the other diet. And then they were asked to do that diet for another 6 weeks. So a 12-week study. And interestingly, at the end of that, there was no difference in between outcomes between the two diets. The patients on the Mediterranean diet said that they had a lot more success in finding foods they could eat, and that their quality of life was probably a little bit better than those on the specific carbohydrate, just because of the difficulty in maintaining it. But honestly, there was not a difference in terms of disease control, and certainly that's a short amount of time to be looking at long-term, outcomes and goals. But it was very interesting that nothing bad happened to either of the groups, but that it looked like the Mediterranean diet was easier to do and potentially more palatable and acceptable. So when my patients say, what should I do? I tell them you should go on a Mediterranean diet.
Yeah, I agree. And Mediterranean diet it's been in the news. It was, diet of the year in 2017, diet of the year in 2022. I mean, every year, the Mediterranean diet is the one to go with. And, just to kind of rehash why, I mean, it is a diet high in fresh fruits and vegetables, nuts, fish, lean protein, whole grains, and they use olive oil as the predominant fat source. So that's traditionally the Mediterranean diet, and it has had awesome results for cardiovascular disease, cancer, death rates, all these things, inflammation. And so that is a common diet, the Mediterranean diet, filled with omega, healthy fats. And then when you look at the specific carbohydrate diet, it's much more, it's much more restrictive. It's like you can have certain fruits and vegetables, but you can't have potatoes, you can have certain legumes, but you can't have chickpeas, you can't have canned fruits and you can't have vegetables because there might be some starches. You can't have milk because there might be, some lactose content or something to that effect. So I think in general, a Mediterranean diet is much easier to follow. And yeah, I think that CD-DINE or DINE-CD study was wonderful because it makes it much easier for us to just recommend to our patients, do a Mediterranean diet. And that's probably the best thing that we could do for Crohn's disease in terms of our understanding.
And you're in Texas, so this will be, this will be heresy. But, if my patient says, well, I'm not sure I can do a Mediterranean diet, the one thing that I will tell them to do is just don't eat red meat. It's full of and if that's the one thing you can cut out, but also soda pop, whichever, or, soda or pop or whatever term you use, that really there's nothing redeeming about soda.
And we should mention when me and Dr. Kane, when we saw each other in Austin at the Texas
we had
GI,
barbecue.
we had barbecue.
Some meat.
Yeah, we definitely had barbecue. It was wonderful. But yeah, I mean, don't eat red meat. I agree. Artificial sugars, processed foods, that is what I harp on with the patients. Please try to avoid as much artificial sugar content and avoid, the highly processed things. That to me is the most important thing. If you get lost a little bit in the weeds of everything as part of the Mediterranean diet, at least if you could remember those things, the artificial sodas, the pops, those sweeteners, that's something to avoid for sure.
Okay, thank you. That's helpful. And of course, if you have questions on this, talk to your doctor, try to help you find a dietitian that's familiar with inflammatory bowel disease, because they can certainly help you get out of the weeds and help you come up with a plan on how to stick to a diet that works for you. So it's a little plug for dietitians, plug for mental health, of course, on this show. Okay, I'm going to back you up just a hair, because I think biosimilars is a question that lots of people are going to have. So can we spend a little more time on biosimilars? Just because I think what's going to be confusing to people is that it's the idea of it being similar is not exact. So it's not like ibuprofen and Advil, where it's like, this is exactly the same thing. That can't be that way because of the type of medications these are. So when they're talking about similar, how similar is it? Like, what is it that's not exact anymore? Can you make that into a patient-friendly comment?
Yeah. I mean, there's this whole idea of bioequivalence. And even if you were to go back, I mean, it's always good to even go back to any medication, right? Like, it's under a certain trade name. And then once the patent is gone, there's a generic version, right? And if you ask pharmaceutical companies, there needs to be, I don't know, it's like 80% of the similar active ingredient, right? Even if you get an antibiotic, right? Even if you get amoxicillin, there's different versions from the generic versus the original, but they have to have 80% of the active ingredient. In this case, it's not as clear, or not as, maybe clean cut to explain like, oh, it's 99% similar. I think the way to think of a biosimilar, it is extremely or highly similar, but it doesn't have any clinical meaningful differences. So I think what everyone needs to think of, a biosimilar. So what they did, and this happened out of Europe first. We're going to go back to Europe. It seems like a very interesting, continent to obviously reference. But patients were on a specific agent, let's just say Humira, and then they were transitioned off to the biosimilar, and they were compared, right? They were compared. What would happen if you went off of one to the other, if you went from the other to the original parent? Would there be any difference? And the truth is, there wasn't any difference, right? There wasn't any difference in those big studies. That's why it became accepted that these changes are going to happen. I mean, there are always going to be minor differences, but when, the FDA will even have articles on this, that there's no clinically meaningful differences. And you might be like, well, what in the world does that mean? But it just means that in terms of the safety, the purity, the potency, the safety and effectiveness, ultimately is not any different, not only, in all the clinical studies and all the, so it's interchangeable is what they use, but it isn't, there's not a clean way where I could say, hey, this new biosimilar of Humira or this new biosimilar of Remicade is 95% similar and maybe there's 5%. In general, what it means is that there's no clinically meaningful significant difference, and it is highly similar, and that's what they use. Those are the terminologies that they have to use.
Got it. So it's really that in order to become a biosimilar, the product has to act in the body the same way as the originator drug. Or like, if it's Remicade, it has to act just like Remicade would in your body, even though it doesn't have exactly the same chemicals in it. Sound right?
Absolutely.
Okay.
That was perfect. You should be the doctor explaining it. That was a beautiful summary. Yes. No. Excellent.
So, but it could be that maybe like a preservative in it is a little bit different or something like that.
Correct. Yeah.
Okay.
Like the buffer, like often you think of the buffer, right? Where they keep the solution, in the case of a, intravenous, or if they even think of like an injectable form, they have to keep it in a certain buffer or a stabilizer to keep the medicine, from denaturing, because it is a protein. So you don't want the protein to denature. So yeah, that might be slightly different than the reference product. Yeah.
Okay. I mean, and, Dr. Kane mentioned that like we will won't switch you. However, your insurance company will. So for those folks who perhaps are facing a letter from their insurance company saying, I know you've been taking this drug and you like it, but I'm going to make you take this other one. We're only going to cover. Well, let me not say it. I'm not going to make you. I'm going to only pay for this other medication, which essentially means that they're making you. So for those patients, how do you talk to them about this switch and kind of potentially alleviate their fears on having to switch to something that's not exact, but is similar?
Well, I think you got to go back to the definition of a biosimilar, right? So you got to, and this is the part that I have to explain to patients. So a biosimilar has to demonstrate that there's no, again, we'll use the term, but there's no meaningful difference between itself, the biosimilar, and the parent or the reference product in terms of both safety and efficacy, right? So that drug, that biosimilar, has had to prove to the FDA that is of the same safety profile and the same effectiveness prior to being, even permitted or approved. So, that should reassure our patients, right? That there's data, that there's clinical trial data, that even if you transition from one to the other, that there shouldn't be a relapse or worsening of the disease process. Now, anecdotal experiences will be different for everyone, right? Like, and you could get easily swayed if you have one patient, even, one patient went from Remicade to, Inflectra, which is, one of the biosimilars, and say they got worse. Well, I might be swayed and tell my patients, well, I've had this horrible experience with one patient, but then you have to go back to the clinical trial data, which is, thousands of patients have had to have gone through this before it was accepted. And so, there's always a song and dance with insurance companies. I face this every single day. Please approve my patient for this drug. Please, my patient wants this drug as their preferred option because it's an injectable and they don't want to do an infusion. Well, the insurance company may turn around and say, nope, you have to go with the infusion first. I mean, so there's a lot of, negotiating, talking with the insurance company to try to get things approved. I always try to advocate for my patients and their wishes. And, if you do run into the situation of they get switched from the parent to the biosimilar and there isn't the same response, we often have conversations with the insurance company and, we could always advocate on our patients, but there's no guarantee that the insurance will cover the parent drug again, which is unfortunate perhaps, but it's the way of the world. And, again, maybe let's harp on the positive, right? The positive is that in studies, it doesn't appear that there is a, downside to switching to a biosimilar. And then let's harp on the other big positive. We have a lot more newer agents. So if there were to be some sort of downturn of events, well, thankfully now we have many more agents available, and there's only biosimilars to two of our drugs, the Remicade and Humira, right? Everyone else doesn't have biosimilars. So we don't have to cross that bridge for the other agents.
Has there been research on people who perhaps go from the parent originator drug to a biosimilar, don't respond to the biosimilar the same way, and then go back to the originator drug? Is that possible?
Yeah, there is. And and so this is, you don't want to get caught too much in the weeds here, but, there is also.
Oh, I'm putting us in the weeds.
No, but there's this whole idea of, belief in a medication working that also perhaps amplifies the results of the actual medicine working. So if you go in there and you're like, there's no way, I hate this drug, I don't think it's going to work, I don't want to go on to this biosimilar, perhaps you're adding stress, and perhaps that's not what's actually triggering, there's not increased inflammation, but you're having stress and anxiety, and that's causing some of your GI symptoms. And then perhaps then when you go back to the parent, there's been some patients who have had the belief that, oh, now I'm good again because I'm on the original drug. Truth be told, it's hard to know if every single one of those patients had, a colonoscopy done and, biomarkers done to assess. But yeah, I mean, certainly it is a conversation worthwhile having with your IBD provider, for sure.
Okay. So you're not going to develop like antibodies or anything like that because it's close enough that if you develop antibodies, you wouldn't be able to take either, correct?
Correct. Exactly. Yeah. Okay. So you could if you develop antibodies to Remicade, you develop it to all the biosimilars. You develop antibodies to Humira, then you develop antibodies to all the biosimilars. So both ways apply.
I'm going to go back to medicines again. Let's stay out of medicines because this is a very
Mhm.
interesting conversation. So I'm assuming there's sort of a care pathway as it relates to like somebody walks into your office and you go through your assessment of them, brand new patient to you, say, has Crohn's disease, and you go through your assessment of them. Is there something that is there a care pathway that tells you what's going to be the best course for that person?
No, that's a fantastic question, because essentially what you're getting at is there some sort of positioning of your Chinese menu of agents that you have now in terms of which patients should get what medication and at what dose and at what frequency, et cetera, et cetera, et cetera. At the moment, we don't necessarily have like, here's number one, here's number two, here's number three, perfectly outlined. There's a lot of agents that are considered first line. And so you can pick any of a number of agents, especially in Crohn's disease. I will tell you kind of my practice. At the moment, Skyrizi for Crohn's disease has been positioned at the top for me in terms of how I approach my patients. So for someone with a brand new diagnosis of Crohn's disease that needs a biologic, Skyrizi is the one I choose. Now, there's many different, almost caveats to that. One of them, if it's fistulizing disease, then I'm going with the TNF agent. If they have psoriasis, that's a point for Skyrizi. If they have rheumatoid arthritis, maybe I'm thinking of a TNF agent. Maybe I'm thinking, so there are different caveats, different clinical scenarios, but there's not a specific answer in terms of which biologic for which patient. The conversation I have, I should tell you, and this applies much more for ulcerative colitis. So if I have a brand new patient with ulcerative colitis, or someone who's had ulcerative colitis for quite some time that needs an advanced therapy, meaning one of the new oral agents that have been approved, the Zeposias and the Rinvoqs, or, has been on previous other agents, I have a conversation, very frank conversation with them about, what type of delivery are you more likely to do? Meaning, are you more likely to take pills by mouth? Are you more likely to do injections? Are you more likely to do infusions? I still face an uphill battle with compliance. Not everyone wants to take the medications at their time. So I have the conversation up front with all of my patients. If all things were equal, would you rather take an oral, like a pill every day? Would you rather, self-inject, perhaps even as far as every 8 weeks, or would you rather go for infusions? And that then almost triggers another part of the algorithm in terms of what the future discussion is. But yeah, it's a complex question, and we could talk probably for hours about positioning of our biologic agents. But some of that also comes down. I've said this before on the podcast with you, but I think really critically, when you think about the best outcomes happen when both the patient and the physician together, they come up with a decision. There's shared decision making. So everybody's on board. Gone are the days of the patriarchal doctors saying, no, you got to take this, you got to do this, you got to do this. No. And I've never been taught to practice that way, but gone are those days. Yep. We need to inform our patients. They need to read about these agents. One of the things I did, I kid you not, yesterday I had a patient with ulcerative colitis that was diagnosed a few months ago in hospital. Severe ulcerative colitis, was put on prednisone and was just told to follow up with me. I didn't see that patient in hospital, was told to follow up with me, and had no idea about any of the advanced therapies, no idea about the biologics, no idea about anything, right? Oral option, injection, infusion, everything was overwhelming to her. Well, I pointed her to the Crohn's and Colitis Foundation website, where you could look under ulcerative colitis and Crohn's disease about all the different treatment options. There's little videos that they could watch. And I pointed her to that website and I said, look, let's continue your prednisone. I want you to read about these agents. Let's come back. Let's have another conversation so that we could get on the same page in terms of what you're more likely to do. But in that moment, she was so overwhelmed by the options and, what to do. So shared decision making, I think, is a good key point in terms of what the patient will like to do and what we think will be very safe and efficacious for them.
Right. I don't remember who said this, but somebody said the best medication for a patient is the one they'll take.
Well, yeah, I mean, what a struggle, right? And if you ask a patient to take, for example, this is not even an IBD, but if you ask someone to take an antibiotic 4 times a day, I mean, chances are they're not remembering to take it 4 times a day, right? Even any kind of it, that's hard to remember. So we need to do something that, our patients will absolutely take, the insurance company will absolutely approve. And there won't be hiccups in terms of, delays from infusion to, et cetera, et cetera.
Yeah. Well, and it's hard because you do have to have a conversation with them about like, what is your lifestyle too? Is an infusion center close to you and you can go over there and work and it's easier for you just to go in there and do that, every 6 weeks or whatever it is? Or, do you need to take medication with breakfast and you don't eat breakfast? I don't eat breakfast a lot of times. So that wouldn't be a great choice for me because I wouldn't remember to take it, or I would take it and I would feel sick and stop taking it probably, so like, what are the conversations? Like, how does this fit into your lifestyle and what works best for you? So that's definitely a good idea.
You bring up an excellent point because, I mean, all of us have our own personal thoughts, right? Like, I mean, even for me, like with the amount of travel that I do, the thought of doing infusions like routinely for me at this stage of my life seems harder, right?
Yep.
Seems harder to like, well, I need to make sure I'm here that day because, my
Right.
life on a week to week or month to month basis takes me, lots of places. And so, correct, to your point, these
Yeah.
things need to be talked about.
Yeah, trying to schedule your life around an infusion maybe isn't the best option for you, but you can
Right.
take an injection with you and possibly do that while you're out and about too. So yeah, that makes a lot of sense.
Well, I will just mention one more trial, which we didn't get to in ACG,
Yes.
which was interesting. It was the combination biologic. So they combined one of the newer medications, which is yet to be approved, called guselkumab, which is an interleukin 23, similar to Skyrizi, as we've talked about, and combined it with golimumab, which is a TNF agent, which we rarely use. And they were looking at, what the outcomes would be. And very interestingly, I will tell you, I don't want to say that the results were underwhelming, but because combination was clearly superior to individual treatments of either of them. But if you even looked at endoscopic improvement, the combination of them reached maybe 50%, at week 38, I think it got to was, maybe close to 50%. And I would have expected those numbers to be much higher than they were, right? So, individually, those agents maybe worked at 25 to 30% on their own, but in combination, they worked up to 50%. So clearly there's a mechanistic improvement there when you combine the two agents. But I was thinking and I was hoping that the number would be like 70, 80% with combining two different biologic therapies. And it wasn't. So, I mean, more to come, obviously, on this. We haven't fully had the whole guselkumab data, and golimumab, as I mentioned, is rarely something that we use in IBD. But, this was interesting, right? This was interesting to see, how this will factor in. And that was for ulcerative colitis, mind you. So, it'll be interesting, as these combination biologic trials keep coming, what will that mean? But I was hoping that number would be higher than 50%, right? Like, I think we're all hopeful to get 70, 80, 90, and ultimately 100%, one day.
I'm curious, how do they decide on what medications to combine, if that makes sense to you? Like, what is it about like the IL-12 and an anti-TNF that you would put together? Like, how do you decide that?
Yeah, like the IL-23. I mean, the truth is that these are pharma-sponsored trials. So, one of the
So you're not in
pharmaceutical
charge
companies.
of it.
No. I mean, we run, like at our center, we're a part of some of these clinical trials. We are a center of recruitment, but, it's ultimately the pharmaceutical company that's sponsoring the trial. They choose which agents they want to combine. But you're right, that is the question. Which combination of biologics? Like, do you combine, I don't know, like Entyvio with Skyrizi? Do you combine Zeposia with Stellar? I mean, I don't know. Like, you can just keep going all these combinations and who knows what. And this is where artificial intelligence may come in, right?
Yeah.
One day, like, are you able to, plug something into this giant database computer that then will spit out, boom, this is the combination for this patient. This is what will get them into remission. And perhaps we'll get there one day. And I mentioned this before, I'm in the field of IBD as an IBD specialist, and I want to see us get to 99.999% efficacy for remission, and we're far from it, right? And if you start thinking, my goodness, we're combining two biologics and our endoscopic improvement, that doesn't even mean endoscopic remission, is barely hitting 50%. Well, we're still way off with figuring out what the heck we need to block, which, we talked about which pathway or which agent or which interleukin or cytokine or mechanism. I mean, we got a ways to go if we're hitting only 50% with using two different agents. So hopefully in our lifetime, this will improve and we'll get better and better.
I mean, we see improvements already. And the fact that, even in Dr. Kane is not like an ancient old lady, in the fact that she was starting with a hug and some prednisone and is now getting to the point where we have, 12 biosimilars for one specific medication that are coming, like, that's pretty darn impressive. And that's exciting to think that there's been this much advancement, even that short amount of time. So I will say, despite the fact that, like you said, it's a little bit of a Debbie Downer to like think about the response rate to some of these medications, there's still a lot that's been done. I am curious though, because before we go down this path, we talked about, Skyrizi feet and skin and how, like that, if you have skin issues and you have, IBD, that might be Crohn's disease, that might be a good option for you. A lot of the folks that it feels like I've talked to lately, or that we've talked to on the show, many of them really struggle with arthritis issues, joint issues. Are any of these newer medications that we're looking at or that are coming down the pipeline, do they seem to be more effective for people that also have joint issues?
Good question. Don't know fully yet. I mean, their mechanism of action is actually not meant for necessarily joints. I mean, you could argue that Rinvoq is, right? Rinvoq is, used in rheumatoid arthritis patients. But the premise in patients with IBD who get joint pain is that a lot of the time we believe that their joint pain is actually related to their IBD disease activity. And without getting too technical here, the point is if you could do a better job controlling the inflammation within the intestines, the better job you can do with controlling the inflammation in the joints and the pain in the joints. So control the inflammation in the intestines, joint pain gets better. And so with the newer agents, perhaps that's what we're doing, right? We're getting better control of the inflammation within the intestines, the GI tract, and that in turn, that spillover effect going to either the skin or the joints or the eyes, that is being reduced tremendously because we're getting better control.
That makes sense. Okay. Well, this was very interesting. I really appreciate the extra time you spent with me too, because unfortunately we had to lose Dr. Kane. So it's just the two of us now, which is unique. So I really appreciate that, Dr. Kwapisz. And I think there's this is exciting to hear about all these new medications coming. It's exciting to hear that we have even more biosimilars coming down the pipeline as well. Just because hopefully more options means reduced costs. Fingers crossed on that one. It's very out of our control.
Yeah. Hard to know. Insurance companies, the fight continues, but we'll continue to advocate on our patients' behalf for sure.
Indeed, we will for sure. Well, Dr. Kwapisz, thank you so much for joining us. Dr. Kane, thank you for joining us as well, even though you're not on the call. So we want to end it by saying cheers, everyone.
Cheers. Thank you for all you do.
If you liked this episode, please rate, review, subscribe, and even better, share it with your friends. Cheers.